the further treatment. What further treatment? So one is BCG. So in BCG, why it is important? Because it has been seen that BCG is superior to TURBT alone or TURBT plus chemotherapy for preventing the recurrence of non-muscle invasive bladder cancer. In previous section, we have just listened that it is very notorious for recurrences. So it prevents recurrence, and not only recurrence, it delays and potentially lowers the risk of tumor progression. If we leave T1 like non-muscle invasive bladder cancer as such, we don't do anything after TURBT, there are chances of tumor progression. So to stop that, we need to use BCG immunotherapy. How it is used? So it comes in vials of 40 milligram. So the standard dose is 120, but mostly we use 80 milligram because of side effects and intolerance issues. We ask the patient to void. There are certain contraindication, we will deal with it later. So if it has to be given, there are different protocols. For intermediate risk cancer, there are different protocol. For high risk cancer, there are different protocol. So how we use it? We ask the patient to void, and then we make it by diluting it in. In these patients, we give it not only for 1 year. The maintenance therapy is continued 6 monthly beyond one year for up to 3 years. So what are the absolute contraindications? We must not use it after 2 weeks of TURBT. We have to wait at least 2 weeks because the bladder is re-epithelialized. Otherwise, there will be intravasation and patient may go into different side effects like BCG sepsis, etc. If we are going for BCG installation and patient tells that I am having reddish urine, blood is coming, we should not give. And if before giving, if by mistake there is traumatic catheterization, blood comes, we should deter it for at least 1 to 2 weeks. And if patient is having symptomatic UTI, we should not give it. I am not going. In patients, our purpose is that tumor should not recur or not progress. So why when we will say that it is treatment failure? If on check cystoscopy at during maintenance we are seeing tumor is present, so there are different parameters we will discuss later. So during that time we have to stop. When we should stop and when we can continue, we will see later. So to be able to specify the subgroup of patients where additional BCG is unlikely to provide benefit, the category of BCG unresponsive tumor was defined. We see that further BCG installation in these patients are associated with an increased risk of progression. So we need to classify these cases. So actually it is bit confusing this term, so I have tried to make some case-like things so that it will be bit easier to understand. So first case is, we have done TURBT has come as non-muscle invasive bladder cancer. We have given BCG. On check cystoscopy had come as a bladder mass, recurrent bladder mass, and we go for a section, and it has come with muscle invasive. So further BCG is not going to be needed. In another scenario, we have given the first induction. Induction course has been given, and at 3 months, there is another mass, and this time histopathology shows it is T1 high grade. Further BCG should not be given, and these tumors are called BCG refractory tumors. At 3 months, and the tumor has come as carcinoma in situ, but there is no other papillary tumor. So we did not say that it is a refractory tumor. We are giving another induction dose of 6 weeks or the first maintenance of 3 weeks. We have seen that in more than 50% cases, there is complete response if it is only a CIS, no papillary tumor. But if it still persists after 6 months of reinduction or first course of maintenance, now it is termed as BCG refractory tumor. Any time during the maintenance therapy, that means after the first induction phase, any time during the maintenance, if a high grade tumor comes, it is called as BCG refractory tumor. Mind it, if low grade recurrence is there, we don't term it as BCG failure and further BCG given, but during maintenance, if high grade tumor is there, we call it BCG refractory tumor. Actually, my discussion is based mostly on European Association of Urology guidelines. So they have categorized BCG refractory tumor in these 4 categories. First, like we discussed, at 3 months it is T1 high grade, or in second case it is TA high grade at 3 months, which may persist on 6 months after reinduction or first course of maintenance. If it is CIS at 3 months, which persists at 6 months after reinduction or first course of maintenance, or any high grade tumor which appears during the BCG maintenance therapy. These all tumors further BCG should not be given. It can be, we will further discuss what to be done in these cases. Now the second is, we have given the induction course and full maintenance dose has been given on during the maintenance phase. We do check cystoscopy before every maintenance this, and there is complete response, no new tumor. But after the maintenance phase has been completed, again a tumor has come. These tumors are called BCG relapsing tumors. But we have seen these are relatively better prognosis than the BCG refractory tumors. Now BCG unresponsive tumors. We have given induction and first maintenance, but at 6 months we are seeing again there is high grade recurrence, whether it's T1 or TA. These tumors are called BCG unresponsive tumors. If CIS develops after complete adequate BCG exposure of within 12 months of complete adequate BCG exposure, it is also called BCG unresponsive tumors. So this unresponsive tumors, EAU says that all the BCG refractory tumors we have discussed, and these cases of high grade recurrence T1 or TA which appeared adequate exposure of BCG within 6 months, or CIS which developed within 12 months of complete adequate BCG exposure, these are called BCG unresponsive tumors. So what is adequate BCG exposure? They have told, in our scenario there is a problem of compliance with patients. There are multiple issues, who is coming with the patient, whether they are coming weekly or they miss any schedule. So to see that at least 5 of the 6 induction doses, or 2 of the repeat induction dose, or 2 out of 6, or 2 out of 3 first maintenance dose, it must be taken. Only then we can see that this is BCG unresponsive tumors. In all other tumors, when dose has been not properly completed, it is not told that these are BCG unresponsive tumors. Now last comes the BCG intolerance. This BCG doesn't come without any toxicity. The toxicity may be in local effects or systemic effects. Local effects is like cystitis, in which we see if there it is because of the medicine or pre-existing disease. It is hematuria, whether there is residual tumor or some other issues. In presence of hematuria, we must never give it. Then it can cause granulomatous prostatitis, in which BCG has to be stopped, or epidermocolitis, in which the temporary BCG cessation may be required. There are general features like malaise, fever, arthralgia, arthritis. But there are 2 conditions of persistent high-grade fever, which is more than 38.5 degrees C for more than 48 hours, and BCG sepsis. In these 2 conditions, there is permanent discontinuation of BCG instillation. If patient present with these features, we call it is BCG intolerance. So how do we treat these cases of BCG unresponsive tumors, late BCG relapsing tumors, low-grade recurrence, or patient with BCG intolerance? So it is said that patient with BCG unresponsive disease are unlikely to respond to further BCG therapy. So radical cystectomy is therefore the standard and preferred option. Further BCG is not to be given. Other treatments other than radical cystectomy must be considered oncologically inferior in patient with BCG unresponsive tumors. So BCG unresponsive tumors, all patients are not fit for radical cystectomy. Neither sometimes they don't want that your whole of the bladder will be removed and we will use your intestine to make a new bladder and there will be a pouch there. Sometimes it is not easy to convince. Sometimes there is patient factors. Patient is poorly built or there are comorbidities. So in these problems, there are other things which needs to be done. So what are those? They are intravesical chemotherapy and microwave-induced hyperthermia, electromotive administrative of chemotherapy, intravesical or systemic immunotherapy. But these all should be given preferably within a clinical trial setting. So, as per the guidelines, if the patient is BCG unresponsive, we can go for radical cystectomy, or we can enroll in clinical trials assessing new treatment strategies, or we can go for bladder preservation strategies in patients who are unsuitable or refusing radical cystectomy. What are bladder preserving strategies? In short, I will tell that sometimes radical cystectomy is not feasible. Then we can go for either single modal or multimodal therapy. Single modal is either go for radiotherapy, chemotherapy, or radical TURBT we say. Or sometimes we do partial cystectomy. Though it is not ideal, but it does some debulking, and we can go for pelvic lymphadenopathy with partial cystectomy. Sometimes these modalities are combined with chemoradiation. We do partial cystectomy or radical TURBT to preserve the bladder in unsuitable patients. For late BCG relapsing, which are TA high grade, which is more than 6 months, and in case of carcinoma in situ, more than 12 months of last BCG exposure, we can go for radical cystectomy or repeat BCG course according to patient's individual situation. These are not early relapse, this is late, more than 6 months for PAT1 tumors and more than 12 months for CIS. Or we can go for bladder preserving strategies. Last, low grade recurrence after BCG or BCG for primary intermediate risk tumor. For these tumors, we can go for repeat BCG, or we can go for intravesical chemotherapy, mitomycin or gemcitabine, or we can directly go for radical cystectomy. Thank you. I tried to be